Hello, everybody. Welcome to the Semandos Campus special webinar series for professionals. My name is Marcio Garcia dos Santos. I am part of BEGO Implant Systems Education and Clinical Research team, and will be the moderator of today's session. First of all, I hope that you and your family are all in good health. Before introducing our speaker, I would like to thank Mrs. Angelica Jacob from BEGO Implant Systems Marketing Department for the organization of this session. The topic today will be digital approach in Periimplantary Pink and White aesthetics, immediate definitive custom abutments, and the speaker will be Dr. Erham Çonlekoğlu from Turkey. Dr. Çonlekoğlu is graduate of EG University School of Dentistry, where he received his DDS degree. He attended prosthesis program of graduate study offered by Institute of Health Science at EG University and graduated with PhD degree at prosthodontics. He's a professor and resident at the Department of Prosthodontic School of Dentistry at the EG University Izmir in Turkey. He completed several scientific projects supported by national and international institutions. He was honored more than 30 national and international scientific awards. With this project, he authored more than 70 articles in peer-reviewed scientific journals in the field of adhesive and implant dentistry and established CAD/CAM restorative laboratory at the dental school. His clinical practice is limited to prosthodontics at the Department of Prosthodontics, School of Dentistry, EG University. Dr. Çonlekoğlu is intensively involved in scientific research regarding adhesive dentistry and implant dentistry. His current research interest particularly covers implant-periodontal interaction and their clinical outcomes. Erhan, thanks for accepting the invitation to conduct this session. As always, at the end of the lecture, we will have a question and answer session, and you can place your questions in the question box during the whole presentation. I wish us all a very nice time, and I give the words to Dr. Çonlekoğlu. So, Erhan, now your microphone is open. Yes.
Thank you, Marcio, and also Angelica and BEGO family for the creation of this webinar. So I think you can hear me now, right?
Yes,
Yeah. Okay. We are on hard days, and we are trying to adapt our new normals. I think from now on, these webinars also will be our new normals. So let's start the presentation. Implant restorations have 3 different colors, as you know, and today we will mostly talk about pink one, the mucosa part. And I want to start the presentation with my first zirconia abutment patient many years ago, maybe more than 10 years ago. She applied to our clinic, and at that time, zirconia customizable prefabricated abutments were new in the market. And they were, of course, very expensive. The high-cost treatment plan was made for her. But I promised her a very good, mostly ideal aesthetic results. But when the treatment was finished, I was a little bit embarrassed because, as you see, the result, the consequence was far from being ideal or aesthetic. What was the missing part? Of course, the missing part was the protocol. The protocol in establishing the pink and white aesthetics, especially in the anterior regions. But later on, incidentally, she came to our faculty, the clinic, once again, 5 years later. And the result was perfect, mostly perfect, 90% perfect, because the best sculpture, the nature, the biology did it very well, because as you see, after 10 years or 11, 12 years, the pink and white aesthetics is very good, in a very good condition due to her very thick phenotype. we will discuss it in this presentation later on. Let's talk about the protocol a bit. We should, in the anterior part, use custom abutments, of course, but why should we use these a little bit expensive parts? It has two reasons. The first reason is every tooth has an individual emergence profile or emergence diameter, but mostly all the implants have the same diameter, approximately 4 millimeters. So for each tooth, we should make not a prefabricated, but a spatially tailored abutment. Therefore, using an individual customized abutment will provide us more aesthetic results. For example, for a central incisor, the emergence diameter is approximately 6.5 millimeters. So with a customized abutment, you can easily manage to get as good support for the papilla. But for most of the abutments, prefabricated or the mass production abutments, you cannot achieve good results. This was the mechanical reason. The second one is the biological reason. Again, I will give an example on a patient. This patient was referred to our clinic due to the color mismatch of her two lateral incisors, and also the emergence profile was not ideal at all. When we removed the crown, we saw that a customizable zirconia abutment was used, but when we unscrewed and removed it from the mouth, we saw that there was an inflammation on the mucosa. But the most important part is on the abutment color, because as you can see, there was some remnants due to the excess cement flow in the pocket, into the pocket. But the mistake was not the cleaning of the excess cement. The mistake was made in the fabrication of the abutment. Now, of course, we finished the restoration with customized abutments, and now they are at the same level. The prosthetic platforms of these abutments are at the same level now, as you can see with the yellow line. But let's look at the buccal margin. As you see, there is a huge difference between the height of the buccal margin or the hole margin. I think the very experienced dentist also couldn't clean or cannot clean this excess cement due to the undercut area. And even after 2 years, the mucosa is in healthy condition, and also we can admit that we have pink and white aesthetics. Two reasons: biological and mechanical. We had two reasons to use customized abutments. Now let's jump into the clinical protocol. First, we start with the first step, I mean the shaping, the temporary restoration. So this temporary restoration is very important in terms of pink and white aesthetics, and mostly in pink aesthetics. With this temporization, you can see the height of the papilla or the location of the pink tissue, the mucosa, before you invest for the restoration or abutment. So we should shape these parts, and in the shaping, in the shaping part, I think it flows now. The shaping part resembles the mock-up in laminate veneer process. We can see the final situation before we invest for the materials in laminate veneers. As you know, we use this mock-up session, and just like this, we can see the final pink situation, the most difficult part, to establish a good pink and white height, the papilla height or the scallop type. So you can see and be sure about the pink aesthetic part prior to investment or prior to making a final crown. For example, for this patient, the situation is very well. So we have to make temporaries, and for this purpose, we use some spatial parts, mostly in BEGO. Of course, you know, we use PEEK material for this purpose. And now I will share 3 different cases in making temporaries three different processes for temporary fabrication. The patient has some difficulties with aesthetics in his left first central tooth, and again from BEGO University, Associate Professor Pınar Meriç made the extraction of the tooth and placed the implants. Of course, prior to implant placement, we measured the buccal plate. Everything was perfect, so we can easily jump to type 1 implantation. We placed the implant. Thereafter, we prepared it. I think we have a slight problem in the flow of the video. Sorry for that. It's due to my internet connection. And we made an artificial tooth into a veneer, and thereafter we luted it with composite material to the peak abutments, and everything seems to be good. We checked the occlusion for static occlusion, of course, and for all the dynamic occlusion procedures, lateral occlusion and protrusion. After all, we torqued it up to 15 Newton centimeters and closed the hole, screw hole. Everything seems perfect. So the first temporization method is using artificial tooth for this purpose. The second one, and also if you have the crown or the crown restoration, like in this patient, she had an horizontal fracture on her left central incisor, and she got the crown restoration to the clinic. You can make a special, sorry for that. Marcio, can I open the low resolution presentation because the videos do not work?
Yes.
Is it okay for you?
No, so it's no problem for us. You can open. We're sorry to the audience about that. We made the test.
Sorry for that. Because
we made 2 tests before.
Okay.
But okay.
The video is recorded. Okay. Sorry for that. Yes. Now I think it flows better. Sorry for the resolution. So the patient has got her fractured crown or the restoration with her, and then we made a template in order to place this crown restoration in place, in exact place. And after that, we made a temporary pattern resin bridge in order to locate this restoration perfectly after the implant placement. The implant was placed, and the crown sorry, it doesn't flow. The implant was placed. We made a hole on the restoration. The implant is sorry for that. We prepared the peak abutment a bit. We made a hole in the crown and then luted it with composite resin onto the peak abutment with the help of this pattern resin temporary bridge. After removal, we cleaned the surface from blood remnants and saliva remnants, and then we filled there with the flowable composites and shaped it accordingly. Later on, we will discuss it again, and checked for the occlusion, and of course, filled the hole with composite resin. This was, again, the surgery was made by Pınar Meriç. And 1 week later, in the suture removal phase, everything seems to be perfect. The second method for temporization is using her or his existing crown. But are they the best temporaries? Of course not. If we have the natural tooth part in our hands, it will be better. Just check this patient. He has a severe problem, a severe caries problem on his, again, left side. After extraction, we should check the buccal plate, and the implant can be placed with type A period. The immediate implantation can be made because the buccal plate was 3/3, it was complete, and the implant was placed, it was torqued, everything seems to be perfect. But let's check the extracted tooth. It has a large caries, and the caries is on the root part. We remove the caries, cleaned the surface, and after that we etched, primed, and make a filling composite resin restoration on this extracted tooth, and cut the tip of the root, and also make a big room, a big chamber inside of this natural tooth. But we didn't touch the outer surface of the root because that part is genetically important. And we checked the location of this temporary made by the natural tooth. Everything seems to be perfect, and we luted it again with the same protocol with composite resin onto the tie base or peak abutment, whichever you use, it doesn't matter, on the newly placed implant. After light curing, we will remove and clean the excess composite resin part in the collar area. But try not to touch the cement parts because it is very important in terms of Sharpei fibers. We cleaned it. And finalized the temporary made of his own root, own tooth, and closed the gap, the screw hole with cotton. Check the occlusion. The occlusion should be checked in 4 different ways: static occlusion, protrusion, left and right protrusions. Everything's perfect. Here is the comparison, the before and after part. Again, in the same hour. The picture on the left is the prior, the before picture, and the second one is implant restoration with a temporary restoration. So before we start, the gingiva level was a bit retracted. After implant placement and after 1 year, because the patient didn't come to the clinic within 1 year, again, the mucosa height is exactly the same. After 2.5 years, he came and we unscrewed. We saw that it was fully attached to the mucosa or the epithelium. It was very interesting to us at those years. But we removed the temporary, and even after only 2 days, please see the retraction in mucosa. So you can think that using a natural tooth, a natural cement or enamel can hold the soft tissue in place. Even after 2.5 years, within 2.5 years, we didn't see any retraction in the mucosa, but even after 2 days, when we remove the natural temporary, we can see the big retraction on the mucosa. So this was because of the type Sharpei fibers mostly, because we can have adhesion on the temporary if we use natural crowns. Check these patients, and we will see a different type of adhesion. In this adhesion, you can notice the adhesion of the epithelium, junctional epithelium, to the natural temporary, natural tooth temporary. Again, I will show it again. Sorry. Now it will flow, I think. check this again. It's like a fridge magnet. The epithelium in the junctional area was attached to the natural tooth. This is very important because during healing process, it holds the mucosa in place and the mucosa cannot be retracted. So the temporization has another advantage, holding the soft tissue in place. It is very important. The best temporary is the natural tooth itself. So this is the situation for this patient. We are experienced, of course. We again used the same temporary in place and made a definitive zirconia hybrid abutment. And as you see, everything seems to be perfect. The margin area is only 1 millimeter below the mucosal line. The abutment fulfills the whole mucosal gap, mucosal cuff. And we don't have a whitening on the mucosa, a big whitening on the mucosa, of course. And we made a crown restoration from Emax Lux. We finished the restoration within only 1 day with digital technology. This was the adhesion of the epithelium. Now I will show you a very interesting case. This case was made 10 years ago, maybe. Again, a patient has suffered from a vertical fracture on the left first central incisor. We extracted the tooth and we saw that there is a big hard tissue loss on the site. So we decided to make a type 3 implantation. Again, we will discuss at the end of this presentation with slides, of course. And I made a midland bridge for this patient. After 4 months, the bone was healed, partly healed, and we made the implant. But at the implant time, we finished the definitive customized abutment on her. At those years, glass ceramics were not on the market, so we used zirconia for this purpose, and we made a definitive zirconia abutment with tie base and made a composite resin temporary on her. But after 1 week during the removal of the suture, you can see the perfect pink and white situation. After 3 months after the osseointegration, we had a slight retraction on the mucosa, as you see. Generally, in normal conditions, we would remove this zirconia abutments and prepare the margin again and reattach it. But for this purpose, for the first time, we didn't remove it. We made a margin preparation in situ. And also, again, we made a digital impression, a very old software of CEREC, and from Vita blocks, we finished the restoration, a glass ceramic restoration, only in 1 session. The most important part was the difference between the marginal levels of the level of the bone around the implant. After 4 months, we didn't see any resorption, but we saw some apposition of the bone. It was very interesting at those years, maybe 9 or 10 years ago. And also the pink and white aesthetic situation after 44 months was very good for these patients. So we decided to make a protocol and decided to make a study on this. This was very important because if we look closer to the proximal area between the implant and tooth, we have different structures, of course, bone, soft tissue, periodontal fibers, and junctional epithelium. But the most important part for pink and white aesthetics is biological width, which means the connective tissue and the junctional epithelium together. And this part is very important because it is a bit different. It differs from tooth to implants. Around the teeth, we have a very good connective tissue attachment to the cement or cement. It is very strict. It's like the Great Wall in China. it avoids the penetration of the bacteria into the bone area. But around implants, the fibers are not attached to the metal or the alloys or the metals. So they are circumferential. Easily, there may be easily penetration of the bacteria to this part. And also, which is very important, if you see whole epithelium part after the removal of the healing abutments, it is a bit dangerous because the connective tissue part in the biological width will adhere to the implant site, and it will resorb a small amount of bone. This, if you see, the mucosal cuff only consisted from epithelium, the connective tissue would resorb the bone around the implant and adhere to the implant collar area. But this was a very interesting case. You can see the bone, connective tissue attachment, and the junction epithelium in only one frame. This was a patient that we used definitive customized abutment, which means one time, one abutment. So for this patient, we could see epithelium and also the connective tissue attachment. Why? Because we placed the abutment at once and didn't remove it again. If you remove the healing cap or abutment once, the connective tissue will be exposed and there will be a wound there. There will be some bleeding there. If you place abutment or healing screw again, the epithelium will close the surface of this wound and the connective tissue area will be diminished. But the connective tissue will continue to resorb the bone around the implants, and it will adhere again within 1 millimeter of height or width. So we will have a bone resorption, periimplantary bone resorption after 6 months to 1 year. Of course, we admit this resorption as physiological, but we saw these kinds of patients after removal of the definitive customized abutment, we didn't see any resorption. We noticed not resorption, but a position of the bone. So we decided to make a study on this. We collected some patients with lateral deficiencies and made 2 groups. In the first group, we applied a conventional clinical protocol. In the second group, we made the abutments, the customized abutment at once and didn't remove it again. And we placed implants. Before placing, we got some CBCT images in order to measure the bone levels. And for the test group, for the definitive customized abutment group, we prepared all the abutments from glass ceramic material, from Emax flux. And now you will see that the adaptation, marginal adaptation of this ceramic part and the tie base is almost perfect, because they are all the whole and the titanium base are prefabricated. And of course, for these patients, it is very important. You should protect the connective tissue area from sandblasting. So silicones or waxes are useful in terms of protecting this area. We made the definitive crowns after dose integration. It looks perfect. But on the other part, we followed the conventional process. We removed the healing part and applied the impression coppings, removed the impression coppings and applied the healing cap again many times. And after that, after 4 months, we finished the restorations, but they were not wholly perfect. The papilla heights were not ideal. We measured some issues in terms of pink and white aesthetics. And of course, on CBCTs, we measured the levels of the periimplantary bone. And we saw that if you use one-time one abutment with customized manner, you will not have resorption even in the labial or the buccal area. Besides, you will have, maybe you may have an apposition. But the most important part is not the numbers. Numbers can lie, but the eyes don't. Clinically, it was not a study patient, it was a routine patient. We placed a definitive customized abutment on her, but you see that connective tissue was adhered on the zirconia, sterilized, customized abutment surface. Now, please check the adhered part. Now, I will play the video. When I try to remove the abutment, some tissue part is moving. And the location of this part is possibly connective tissue attachment. You can adhere connective tissue on the abutment. So during the healing process, it will hold the whole pink part, the mucosa part, in place. So you may not have, mostly you may not have retraction in pink part. So let's talk about some scientific data on this protocol. I mean the protocol rules. The first one is phenotype of the patient is very, very important. Of course, we have two main different phenotypes. The first one is thick, the second one is thin. The characteristics of thick is they, from the beginning, from the birth, they have a thick buccal plate, and also the width of the connective tissue or the mucosa, the thickness of the mucosa is bigger, larger than the thin phenotypes. Therefore, mostly in clinic, we apply some different placement protocols for thin phenotypes, of course. But I will share two different patients in this for this purpose. The first patient was our 78th patient in these protocols, and her name was 78, number 78. We made everything perfect. This is the temporary. After 4 months after osseointegration, the right central incisor was missing, and we placed an implant. We made a definitive abutment on her, and also we made a composite resin temporary. After 4 months osseointegration, everything, the papilla height, the sharpness of the papilla seems perfect. But after the final situation, and after 1 year, when we finished the restoration, final restoration, we saw a retraction in the papilla, which means not a success. This means it is not a successful therapy. But the patient that I showed in the beginning, in the very beginning, we hadn't had any papilla from the beginning in the first phase, but after 5 years, all the papilla parts were full, because the first patient had very thin phenotype, and the second patient has a very thick phenotype. So the thick phenotype is your friend. Don't forget it. Second one is the most important and most scientific part, the timing of the implantation and also the restoration. So when we extract a tooth, we can have different situations. But the first situation is we will have a resorption, and mostly on the buccal area. The buccal bone plate, the bundle bone area will be lost. And even for the posterior teeth, when you extract a molar tooth, mostly 4 millimeters in height and 25% in width, you will have a bone loss in this area. So there are lots of scientific literature on this, and there are two main streams. I follow the Zurich and Harvard protocol from Gallucci and Daniel Buser. According to them, there are 4 different types of implantation periods. Type 1 means immediate, type 2 means 8 weeks after extraction, which means you will have a healing in mucosa. Type 3 means 12 to 16 weeks, which means you will have a partial bone healing in that area. And type 4 means the most undesired one, above 16 weeks, means full healing in bone. And according to loading timing, we have 3 different groups. Immediate means A, 1 to 8 weeks means B, and over 8 weeks means C. And according to scientific literature, there are different survival rates, but these survival rates don't mean success rates. Now I will show you unsuccessful cases. The survivals will be 100%, but we won't have a success in pink and white aesthetics, as I shared. The most important knowledge on this is type A. Of course, everybody likes type 1. Type 1 means immediate implantation. When you extract tooth, you will place the implants. Both the dentist and the patient will be happy because the patient will have a temporary crown and aesthetic result after the operation. But within type 1, after 1 year, in the 20 or 30% of the patients, you will have a 1 millimeter of buccal bone resorption and buccal soft tissue recession. So we should obey some rules. The first rule, the very important part, is the situation or the height of the buccal plate, but not after the extraction, just before the extraction or during the extraction. So what should we do? After the extraction, we should measure this area. This area should be divided into 3 subgroups. 3 over 3 means we will have a complete buccal bone, but 1/3 means only 1/3 of the buccal plate is in situ. So let's talk about the protocols. After the extraction, we are measuring the buccal bone, buccal plate. So for this patient, a slight resorption in this area is present. We can consider type 1. Again, for this patient, after the extraction, buccal bone is complete. So type 1 implantation can be made. So it is within the normal range, normal biological width. The protocol: if you have complete buccal bone and thick bone phenotype and gingival biotype, and also if there is not infection in the implant area, we can make type 1 implantation. But if the buccal bone thickness is below the counterpart, of course, you should be very careful, because this will mean an aesthetic complication after 6 months. So 2 things. The first one is the height of the buccal plate should be 3 over 3, and also the thickness of the bone should be enough. According to a study, they say that in premolar zone, you will have a thick buccal bone phenotype, but not in the central area. Only 5% of our patients will have sufficient buccal bone thickness. This is very important, and I will show you some unsuccessful cases in terms of selection criteria. First patient, a vertical crack on the left central incisor, and we have a bone defect on that area, but she is not suitable for type 1 implantation. But we placed the implants, we made a temporary. After 4 months after osseointegration, you can see the result. It is not successful because we lost the papilla. And we made the restorations, but we should make a restoration on the other central incisor in order to close this papilla gap. It is not successful, and the success was achieved with a prosthetic contact, a prosthetic approach. In this case, we should apply type 2 implantation, which means we should wait for 8 to 12 weeks in order to get a complete healing on the mucosa. So there will be more blood on the area, and the tissue response would be better for this patient. If the bone resorption is bigger than 2/3, if it is in the 1/3 zone, we should be very careful because the scientific literature recommends make type 3 implantation for this kind of patients. Type 3 means if you have less than 1/3 of the buccal bone height and also the bone phenotype and gingival phenotype are thin, or there is infection. If an infection is present, you should apply type 3 implantation. I will show you a case. Even with type 3 implantation, you may not have the pink and white optimal aesthetics. In this case, there was mistreatment in endodontics. As you see, the root was perforated with a file, and all the buccal bone area was resorbed due to the inflammation. Of course, he is suitable for type 3 implantation. The socket should be preserved, and after after grafting and 4 months for healing, the implants and the temporary was made. Here is the healed situation. We don't have the papilla in the mid-central area 100%, but it's not bad for this patient. And of course, to make a foot papilla, we should make a restoration on the counter central incisor as well. And in this patient, we decided to make a laminate veneer because the enamel condition of the tooth was very good. And for this patient, abutments, crown, and a laminate veneer was made. Here is the final solution. The third rule is the cervical design. According to the literature, the cervical design should have 2 parts. This means we should divide the abutment into 2. The first part is between the implant prosthetic platform and half of the abutment, and the second part is the emergence part and half of the abutments. In the first half, the abutment should be as thin as possible because we should spare some space for the connective tissue in this part. And also, you should be careful in establishing the emergence profile and the convergence angles. For example, for this patient, if you divide the abutment into 2, the connective tissue part, I mean this part, is thin like a pipe, and the other part was fabricated according to the lost tooth, the diameter of the lost tooth, lost premolar. But you should care also this. If you use a stock abutment, the margin should be placed only 1 millimeter below the mucosa line in order to clean all remnants of the excess cement. But of course, if the emergence profile is larger or there is a huge difference between the implants and the lost tooth diameter, you will have a convergence angle of convergence angle more than 30 degrees. And in order to decrease this convergence angle, you should place the margin close to the prosthetic platform of the implant. So for this restoration, you will have a convergence angle of approximately 30 degrees or less than 30 degrees. But the margin is now under the mucosa and the excess cement cannot be cleaned. This should be a screwed type restoration like this. But for this patient, the papilla height is very good. The scallop line is very good, very aesthetic, but it is a screwed molar because for this patient, the margin line was located near to the implant prosthetic platform. And if you would make a normal restoration, you wouldn't clean the excess cement. This convergence angle and screw line procedure is important. What can we do for this type of patients? After shaping the mucosa, As you see, the position of the implant is a bit deep. You can make an impression according to the hints technique, and the technician will fabricate the restorations according to the emergence profile that we created with the temporary. The margin line will be very close to the prosthetic platform of the implants. So I have a problem with video again. Yeah, now it's okay. So the margin of the thigh base is very close to the implant, but the emergence profile is as we shaped with the temporary restoration, and after the final crown restoration, the papilla heights and the scallop line seems aesthetic. Regarding the selection of the material, we have different types of materials. Of course, in the anterior region, titanium or metal alloys are not the appropriate ones. Maybe the most beloved material for this purpose is zirconia. Zirconia is very tough, but it's not aesthetic. For example, if the collar area of the if we have a mucosal retraction and the collar area of the zirconia abutment is exposed, it will be easily distinguished by the patient or the others. So for this purpose, we should use glass ceramics in terms of fabrication of abutments, especially in anterior region. Again, I will share a patient for this purpose. A premolar was placed and it was shaped. Later on, we applied a thigh base and we made the abutment part from the glass ceramic Emax abutment, because as you know, it is very strong and also aesthetic. It is very strong because it has lots of crystals inside and every crystal can stop the crack immediately. But it has a glassy matrix, which means it is just like a natural tooth in terms of translucency. We fabricated the abutment part, crystallized it, and after then we luted it onto the thigh base with anti-rotational. As you see, there is an anti-rotational part. The most important part is you can finish the margin line supramucosally. And after luting the restoration with a suitable cement color, you will have a perfect match, perfect color match between the abutment and the crown. And even after a retraction in the mucosa part, it will not be easily distinguished. You can use this material for posteriors. There are two very sound scientific literature support for this. After 1 million cycles of 100 kilograms, these materials can withstand, which is very sufficient. The fifth rule is contact point is very important in terms of tooth morphology. Check out this patient. This patient was suffering from an aesthetic, non-aesthetic crown restoration on her lateral tooth, because as you see, the approximal contact area was not fabricated properly. As we removed the restoration, we saw that we can increase the height of the papilla, but the important part is, the very important part is this: where should the contact point be? If the papilla cannot feel the contact point, cannot reach the contact point, you will have dark triangles between the implant and the natural teeth. So it is very important. But if you calculate it properly, as you see, you can have full contact height, full papilla height in the approximate contact area. How can we manage this? Again, for this purpose, we should check the scientific literature. It was made from the group of Salama and Dennis Tarnow, maybe 30 years ago. The papilla height is the papilla height is important, and between the bone, marginal bone tip and the contact area, you should have over 4 millimeters, 4.5 millimeters between implants and tooth. If you have this height, the papilla can fulfill the whole gap. So there are different techniques for this purpose. I'm using the radiographic technique, which means after implant placements, I immediately have a periapical radiograph and measure the diameter of the implant on the radiograph. For example, for this case, it was 4.5 millimeters, and the real diameter of the implant is 4.1 millimeter. So I have a magnification value of 1.1. The papilla height should be 4.5. If you multiply it with magnification value, you will have 5. 5 means the distance on the radiograph should be 5 millimeters between the buccal bone tip and the contact area. But we have two different bone heights here. The bone closer to the natural tooth, neighboring tooth, and the bone closer to the implant. The literature says that natural tooth bone height is more important than the other. So I will measure the 5th millimeter on the radiograph. This part should be the contact point. In order to locate it in the clinic, in the patient's mouth, you can locate a reference point for this purpose. The best reference point is the incisal point of the neighboring tooth, and for this patient it was 4.8. If you divide it to the magnification value in the clinic, I should mark the 4.4 area in order to make a contact. So I make a temporary restoration which is smaller in the beginning, and with flowable composite resin I apply small parts in order to make the perfect approximal contact areas. So in this red arrow part, we will establish the contact point. After only 1 week in the suture removal phase, you can see that the papilla completely filled the gaps because we measured it perfectly. If you don't obey these rules, for example, for this patient, it was an unsuccessful patient. Let's measure it. This point was the contact point of the temporary, but if you measure the distance between the buccal bone and the contact point, it is more than 6.5 millimeters. And the correct height should be 4.5 millimeters, this point. And again, in the clinical picture, you can easily see that the papilla would heal only to this height. I mean the 4.5 millimeter height. And the last rule is the neighborhood. Neighborhood means we should select the diameter of the implants or make some orthodontic therapy to the patient before inserting the implants, and we should obey the distance rule, which means the distance between the implant and the root of the neighboring tooth should be more than 1.5 millimeter, maybe 2 millimeters. Because with these width, the papilla can be fostered more properly. If it is below 1 millimeter, after 1 year or 6 months, you will have a resorption due to the biological width location around the implants. And if the distance is below 1 millimeter, this resorption will affect the bone height on the neighboring tooth. So you will have a resorption around the natural tooth, neighboring natural tooth, and the papilla may be retracted a bit. And within 2 implants, the distance should be 3 to 4 millimeters. So last part is I could only find this literature, this randomized clinical trial on this. If the lost teeth is a lateral incisor, the distance between the two neighboring teeth should be at least 6.7 millimeters. If not, for example, for this patient, the distance is below 6.5 millimeters. So as you see, I manufactured the thinnest abutment as possible, the possible thinnest abutment for this patient. But even with this abutment, you can notice that the width of the papilla is not sufficient. So for this patient, I couldn't reach the natural papilla height, and unfortunately, I carried the contact points to the gingival area a bit. So the crown seems to be more rectangular. But again, it seems it can be thought successful as well. And also, if I have time, I have only a 1 minute video. Marcio, may I show a 1 minute video? Do I have enough time?
Of course.
Last slide is a video. 4 years ago or 5 years ago, I was thinking that the implant dentistry or the dentistry would be single visit dentistry in 2020, but today we see that it was not possible, it's not possible, or it is not possible yet. Single visit dentistry means we should finish the definitive custom abutments, the restorations, and also even the laminate veneers for the neighboring tooth at the same time, in the same appointment. I will show this technique with a patient, and this patient was suffering from a severe retraction on the mucosal part on an existing implant. And this part was this part was healed or treated with Zucchelli technique by Serhat Aslan, and the temporaries were made, were healed. Sorry, Marcio, the video didn't flow very well, but in the single appointment, at that course program, we made 2 customized abutments, 2 crowns, Emax crowns, and 2 laminate veneers for the laterals at the same time. So the CAD/CAM technology can allow us this type of treatments also. But to me, the last word, manufacturing these restorations only in 1 appointment is not the important thing. The important thing is to establish the correct marginal heights, the correct papilla heights. And of course, in prosthetic point of view, we should know the contact points properly, and also the depths or convergence angles or emergence profiles of the lost teeth. Thank you, Marcio. I finished my presentation, and if we have some questions, I will be very happy to hear them.
Yeah, dear Ehan, I believe you can open your camera. First of all, thanks so much for the very didactic and the clinical presentation.
Marcio, can you hear me?
I hear you. Your camera is unfortunately not showing now. Yes, but I believe you can hear me. So so again, thank you very much. It was very didactic, very clinical. After our test, to everybody I spoke after our test, I was saying that it would be very worthy to attend your presentation, because you will show very nice clinical cases, very beautiful clinical cases, and I believe everybody now agrees and are happy with what they saw today. Thanks for dealing so good and so calm with the connection problem. We apologize to everybody. We made 2 tests, as I said, in the last weeks, but unfortunately, connection quality is something that we cannot predict. So again, we apologize everybody for our connection problem. We receive here first compliment. The presentation was very good. We come from first participant. It was really very nice. Amazing. Come from the colleague from Portugal, Bruno Seabra. And Bruno is a guy that has a photo course, so he teaches photography, and I'm pretty sure Bruno was very satisfied with the quality of the photos and videos he has his course. And one question that come is that we don't see so much soft tissue procedures in your clinical case. Do you believe with the individualized abutment you can manage your soft tissue? How often did you do soft tissue procedures in your cases?
In this presentation, I approached only from the prosthetic point of view, from the restoration point of view. But of course, as I showed the protocol of Zurich or the protocol of Gallucci, if it is type 1 and the buccal plates height or the mucosal volume is sufficient, the soft tissue intervention would be minimal. But if it is not, and if the situation is with thin phenotype or thin bone phenotype, and you want to make an implant at the same time with the extraction, of course, you should apply some soft tissue interventions, but it's not my profession area, so I only wanted to share the prosthetic or the restorative part mostly.
When you do the one abutment, one time approach, which material you prefer to use already in your in contact with your abutment, your tie base?
We made a study and it will be published very soon. Zirconia is far better than the glass ceramic material because the surface of the zirconia is more stable than glass ceramic. I can say glass ceramic is zirconia and the titanium are the best ones, and later on glass ceramic comes.
Thank you very much. Two colleagues from BEGO, two friends from you, send you the congratulations. One is Ralf Lexig, and the second is Dr. Nina Kuhakski. So both of them are congratulating you for.
Thank you very much. I'm very happy to hear
for the presentation. Yeah, I believe that was the question. So also from again from our side, Erhan, thank you very much for accepting the invitation.
Thank you.
Hope to meet you again soon. And also, so to everybody, I would like to thank for the participation. Thanks for the understanding about the connection, and hope to see you soon in another webinar.
Thank you very much, Marcio.
Thank you, everybody. A nice day. Bye bye.
Goodbye.